Your physician just booked you for a routine checkup. You nodded, said okay, and didn't think twice. But by the time you finish watching this video, you may never approach a doctor's appointment the same way again. Here's something I rarely hear my colleagues say out loud. After the age of 70, certain routine medical tests can actually do more damage to your health than good. And the medical system is not set up to tell you that. My name is Dr. Adriana Markson. I've dedicated over 3 decades to internal medicine and geriatric care, helping older adults figure out one of the hardest questions in medicine, when getting tested is the right call and when it quietly puts you at risk. Today, I'm going to walk you through 5 routine screenings I personally would decline after turning 70. This isn't me rejecting medicine. I believe in medicine deeply. But I've spent years watching what happens when these specific tests are applied to bodies in their 70s and 80s, and it is not the success story most people expect. Before I get into the list, I need to explain one concept that changes everything. I call it the screening equation, and after age 70, that equation shifts completely. At 50, screening is almost always worth it. You catch something early, you treat it, and you've got decades ahead of you to benefit from that decision. The numbers make sense. But once you cross 70, 3 critical things happen that flip the math upside down. First, a large number of abnormalities, including many cancers, grow so gradually that they will simply never create a problem in your lifetime. You would live alongside them and eventually pass away from something else entirely, never once feeling their effects. Second, the older body tolerates procedures very differently. Biopsies, surgeries, sedation, recovery periods, all of it becomes riskier. What a 52-year-old bounces back from in 2 weeks can take a 77-year-old months, or might trigger complications that never fully resolve. Third, and this is what keeps me up at night, there is something called the cascade effect. One slightly unusual test result leads to a follow-up scan. That scan leads to a biopsy. The biopsy leads to a recommendation for surgery. The surgery leads to a complication. And a person who walked in feeling completely fine is now navigating a medical crisis they never needed to enter. I have watched this play out more times than I can count. So let's talk about the 5 tests. Number 1, routine colonoscopy after age 75. I want to tell you about a patient I'll call Eleanor. She was 76, retired, mentally sharp, and still tending her garden every single morning. Her doctor told her she was overdue for a colonoscopy and strongly encouraged her to schedule one. Eleanor hadn't been having any digestive issues whatsoever, but she trusted her doctor and moved forward. The prep alone became a crisis. The heavy laxative regimen left her severely dehydrated, her electrolytes completely off balance, and her heart going into an irregular rhythm. She was rushed to the emergency room before the scope ever happened. Here's what many people don't realize. The United States Preventive Services Task Force, one of the most respected medical advisory bodies in the country, formally recommends against routine colonoscopy screening for average-risk adults over the age of 75. The data shows clearly that past that age, the potential risks begin to outweigh the realistic chance of catching something that would actually shorten your life. Bowel perforation during colonoscopy happens in roughly 1 out of every 500 procedures. In a younger adult, that's serious but manageable. In a frail 78-year-old, it can mean emergency abdominal surgery, a permanent colostomy, a prolonged hospitalization, and in some cases, it's fatal. If you're past 75, have no symptoms, no significant family history, and your prior colonoscopies have come back clean, ask your physician whether a simple annual stool-based test might give you the same peace of mind with far less risk. Number 2, aggressive breast and prostate cancer screening in your late 70s and 80s. Let me be precise here, because this topic is easy to misunderstand. I am not telling you to ignore cancer. I am telling you that in older adults, aggressive screening very often leads to overdiagnosis, which leads directly to overtreatment, and that overtreatment can devastate quality of life. Research published in the New England Journal of Medicine found that roughly 40% of breast cancers detected by mammography in women over 70 are what doctors call indolent tumors, slow-growing, unlikely to ever cause symptoms, and almost certainly not the reason the patient would die. But once a radiologist writes the word cancer on a report, the process kicks into motion automatically. Biopsy, surgery, radiation, chemotherapy, each carrying real and serious side effects in an aging body. The same dynamic plays out constantly with prostate cancer. Elevated PSA levels are extremely common in older men, and the vast majority of the time they reflect normal aging, not dangerous disease. But an elevated number sends patients to biopsy. Prostate biopsies trigger infections in about 5% of cases, sometimes requiring hospitalization. And if they find the slow-growing cancer they were likely to find, the conversation turns towards surgery or radiation, interventions that can leave a man incontinent and impotent for the rest of his life, for a cancer that his body likely would have coexisted with peacefully. I had a patient, I'll call him Harold, 82 years old, a retired school administrator who is still active and sharp as ever. Routine visit, slightly elevated PSA. Biopsy confirmed a low-grade prostate cancer. His urologist recommended surgery. Harold agreed. Half a year later, he told me he would undo that entire process if he could. The cancer was not going to kill him. The treatment took something from him he never got back. If you're over 75 and your doctor recommends a cancer screening, ask this one question directly. If this test finds something, what would we actually do about it? And would that treatment genuinely improve how I live? Or would it mostly just give me something to worry about? Number 3, routine cardiac stress testing. This one concerns me the most, honestly, because it sounds so sensible. A doctor says, let's just take a look at how your heart is performing. You walk on a treadmill or receive a chemical stress agent. It feels like responsible medicine. But the problem is the false positive rate. In asymptomatic adults, cardiac stress tests produce false positives in up to 40% of cases in certain populations. That means nearly half the time the test signals a potential problem when the heart is actually fine. But that signal cannot be ignored. It gets investigated. The next step is typically a cardiac catheterization, a procedure where a thin tube is guided through the groin or wrist directly into the heart to look for blockages. That carries real risks, bleeding, arterial damage, and in rare but documented cases, a heart attack or stroke triggered by the procedure itself. And if the catheterization shows a partial blockage, which it almost certainly will in any adult over 70, because partial blockages are nearly universal at that age, the conversation often turns to placing a stent. Here's the critical fact most patients are never told. Multiple large clinical trials, including the landmark ischemia trial, have demonstrated that stents placed in patients with stable heart disease provide no advantage over medication and lifestyle management in terms of preventing heart attacks or extending life. So the journey goes: feeling completely healthy, routine stress test, false alarm, catheterization, stent, lifelong blood thinners with bleeding risks. And your actual outcome is statistically identical to what it would have been if you had taken your prescribed medication and gone on a daily walk. If you have no chest discomfort, no breathlessness, no symptoms of any kind, a routine stress test is searching for a problem in a place where, at your age, it is almost guaranteed to find something. And in geriatric medicine, that is a very dangerous kind of search. Number 4, routine bone density scanning. I already know the pushback to this one. Falls are one of the leading causes of death in older adults. Bone density matters. You're right on both counts. But follow the logic with me here, because it breaks down quickly. A DEXA scan reveals low bone density. The doctor prescribes a bisphosphonate medication, something like alendronate. You take it faithfully for years. And then something completely counterintuitive happens. Long-term bisphosphonate use is associated with atypical femur fractures, an unusual type of thigh bone break that the medication itself can contribute to. These drugs are also linked in some patients to a condition called osteonecrosis of the jaw, where the jawbone begins to break down in a way that is painful and remarkably difficult to treat. Meanwhile, the single intervention with the strongest evidence for preventing fractures in older adults has no side effects, costs almost nothing, and most doctors spend very little time discussing it. It's fall prevention. Balance training. Removing slippery rugs and loose courts from your home. installing grip bars in the bathroom, getting your vision checked regularly, reviewing every medication you take for side effects that include dizziness. These practical changes reduce fracture risk more meaningfully than any pharmaceutical. I'm not suggesting you stop a medication your doctor has already prescribed without discussing it first. But if a routine DEXA scan is being recommended and you have no history of fractures, it's entirely reasonable to ask, would investing that time and energy into a fall prevention program serve me better? Number 5. Routine carotid artery ultrasound screening. This may be the most quietly dangerous test on this list, precisely because it sounds like the most logical thing in the world. A probe on your neck. A quick look at the arteries feeding blood to your brain. If there's a blockage, you catch it before it causes a stroke. What could possibly be wrong with that? Here is what's wrong. If you have no symptoms, no mini strokes, no brief episodes of vision loss, no sudden weakness on one side, and a scan finds a significant blockage, the recommended treatment is often surgery to clear that artery. That surgery, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke in the process of trying to prevent one. In older adults, that risk climbs higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in people without symptoms. Their thorough review of the evidence found that in asymptomatic patients, the harm potential of the surgery, stroke, heart attack, nerve injury, outweighs the realistic benefit. I received a call once from the family of a 79-year-old man I'll call Raymond. He had gone in for a routine wellness visit, the ultrasound was added on, a blockage was found, and a vascular surgeon recommended the procedure. Raymond walked into that hospital independently. He walked in talking with his family, making plans for the holidays, completely himself. He left with a stroke that permanently affected his ability to speak. The blockage that prompted the surgery had likely been there for years, silently, harmlessly. The attempt to fix it created the catastrophe everyone had been afraid of. Now, I promised you something you could use starting today. So here are 4 questions I want you to write down right now, put into your phone, and bring with you to every appointment from this point forward. I call this the 4 questions framework. Question 1. What is this test specifically looking for, and what happens next if it finds something? Question 2. If something is found, what would treatment look like at my age, and what are the real risks of that treatment for someone my age? Question 3. What is the actual risk of not getting this test? What does the evidence say about doing nothing? Question 4. Is there a less invasive option that still gives us the information we need? A physician who respects you and your well-being will welcome every single one of those questions. If your doctor seems annoyed, dismissive, or impatient when you ask them, that reaction itself is important information. And I want to be unmistakably clear about one thing before I close. I am not asking you to avoid doctors. I am not asking you to ignore your body. If you notice blood in your stool, get that colonoscopy. If you feel pressure in your chest, get that stress test. If you've had any kind of neurological episode, absolutely get your carotid arteries evaluated. Symptoms change the entire risk-benefit calculation. What I'm talking about today is routine screening in people who feel completely well, the let's just take a look kind of medicine. That specific kind of screening carries a very different equation after 70. For 30 years, I have watched patients come through my door healthy, hopeful, and trusting, and I have watched the cascade turn their lives upside down. Not because anyone was careless, not because anyone intended harm, but because a system built to find abnormalities and treat them does not always stop to ask whether treating them will genuinely make a person's life better. You have the right to ask that question. You have the right to fully understand the risks before you say yes. You have the right to say, not yet. You have the right to say no. This is your health, your body, and your life, and no one should be making these decisions without you. If this gave you a new way of thinking about your healthcare, please subscribe. I create content like this every week specifically to help people over 60 make genuinely informed medical decisions, not just go along with the system. And leave a comment below. Have you ever had a routine screening that opened a door you wish had stayed closed? Your experience matters. I personally read every response, and your story could be exactly what someone else needs to hear before their next appointment. See you in the next one.